We start immediately since we are already about 15 minutes late. So
Okay.
disorders of the extrahepatic bile duct. And we are going to start with what is referred to as a biliary atresia. From these, from the lectures which you have already had, I'm sure you have seen that in most of the organs or systems, we start with the congenital malformations, and then we go to the inflammation, and then we finish with the tumors. So this is the way it is supposed to be for disorders of most of the organs, and that is how we are going to do it, both the extrahepatic biliary system at the same time the pancreas. So we start with the congenital malformations of the extrahepatic bile ducts, and the commonest is what we refer to as a biliary atresia. And biliary atresia is a major contributor to neonatal cholestasis. And when I talk about neonatal cholestasis, that is where there is an obstruction to the bile flow during early life. And biliary atresia generally means where there is complete obstruction of bile flow, which is caused by either destruction or absence of part of all the extrahepatic bile ducts. So there are people who are born without the extrahepatic bile ducts, and when people are born without the extrahepatic bile duct or part of the extrahepatic bile duct, we call that biliary atresia. There are some other people who are born with well-formed extrahepatic bile ducts, but early in life there is destruction of those bile ducts immunologically as an autoimmune disorder. They are born normally, but the bile ducts are destroyed by the immune system early in life, and when they get destroyed, of course, the patient presents again with the cholestasis, and that is another cause of biliary atresia. So the point to note is that there are those who are born without, and there are those who are born with, and then there is destruction early in life in biliary atresia. So what are the features? Next slide. So what are some of the characteristics of biliary atresia? And the first one is that there could be inflammation and the fibrosing stricture of the hepatic or the common bile ducts. And as I said, some people are born with the bile ducts, but they are destroyed early in life by the immune system. So if you look at those bile ducts early in life, for those who are born with them and then they are destroyed, there is inflammation. And then I've already said that there is inflammation of the major intra and extrahepatic bile duct. So where there is destruction, there is destruction of both the intra and the extrahepatic bile ducts. When you take a liver biopsy, it shows features of biliary obstruction, and the features of biliary obstruction, when you look at the microscopy of the liver, you will find bile stasis. You will find bile stasis within the hepatocytes or within the liver when you do histology. And then the other thing that happens is that there is periportal fibrosis. And if it is not corrected, these are people who eventually get liver cirrhosis quite early in life. So if biliary atresia is not corrected, then these are people who will end up getting liver cirrhosis within the first 3 to 6 months of life after birth, if there is no correction to the bile flow. So next slide. So how is biliary atresia classified? And it is usually classified predominantly depending on the site of the atresia. And there is what we call type 1 biliary atresia. And in type 1 biliary atresia, there is obliteration of the common bile duct. The proximal ducts are still patent. Obstruction occurs within the common bile duct. Then we have the type 2 biliary atresia, which is usually characterized by atresia of the common hepatic duct. And most often you will find that there will be cystic structures found around the porta hepatis. When I talk about the porta hepatis, I know you know the anatomy, you know what I'm talking about. And then we have type 3, which is the commonest, which occurs in more than 90% of individuals. And the atresia involves the right and the left hepatic duct. That is to the level of the porta hepatis. So a common multiple choice question is which is the commonest type of biliary atresia, and you're expected to know that type 3 is the commonest, which occurs in more than 90% of the patients, and the atresia involves either the right or left hepatic duct or both. Next slide, can. So there is again what we call a secondary biliary cirrhosis, and the secondary biliary cirrhosis is as a result of a prolonged obstruction of the extrahepatic biliary tree. So if there is prolonged obstruction of the extrahepatic biliary tree, eventually the patient will get what we refer to as a secondary biliary cirrhosis. So for patients who have prolonged obstruction of the biliary ducts, eventually they get liver cirrhosis, and this is what we refer to as a secondary biliary cirrhosis. And what happens with the obstruction of the bile ducts is that secondary inflammation occurs, and this secondary inflammation initiates periportal fibrogenesis. That is fibrosis around the portal tracts. And when that happens, eventually the patient will get liver cirrhosis as a result of that obstruction. Subtotal obstruction of the bile ducts again may promote a secondary bacterial infection of the biliary tree, or what we refer to as a ascending cholangitis, and this may further contribute to the damage of the liver. So the point to take home in these slides is that with the continued obstruction of the bile ducts, eventually the patient will get liver cirrhosis, and this liver cirrhosis is what we refer to as a secondary biliary cirrhosis, and this occurs as a result of inflammation. At the same time, secondary bacterial infection that occurs with the obstruction of the extrahepatic bile ducts. So we can go to the next slide. Then there is what we refer to as the choledocholithiasis and the cholangitis. These are very long names. Choledocholithiasis, and the choledocholithiasis simply means the presence of stones, or the presence of gallstones within the bile ducts. So you will find that when the gallstones are found within the gallbladder, we refer to that as cholelithiasis. When these stones are found within the biliary tree, or when they are found within the bile ducts, we refer to that as the choledocholitis. And then cholangitis simply means inflammation of the bile ducts. And when there is inflammation of the bile ducts, we refer to that as cholangitis. So choledocholitis, presence of stones within the bile ducts, and then cholangitis is a term that is used to refer to as to the inflammation of the bile ducts. So the symptoms that occur when somebody has a stone within the bile ducts develop, one, because of biliary obstruction. Of course, when there is a stone within the bile ducts, the patient is going to present with the features of obstruction of the bile duct. Bile duct is in form of the patient will present with jaundice when there is obstruction of the bile ducts. The patient may present with the pancreatitis, and as we are later going to see, when there is obstruction of the bile ducts, the patient may present with the pancreatitis. Cholangitis, that is inflammation of the bile ducts as a result of the obstruction of the bile ducts. They may present with the hepatic abscess, and how the hepatic abscess come about is that with obstruction, of course, there is a bacterial infection. When you obstruct any duct, then of course you predispose the patient to the infection of the duct, and as a result of this infection, and then ascending infection to the liver, the patient may present with the hepatic abscess. The other presentation could be chronic liver disease, and as we had already referred to, there could be secondary biliary cirrhosis. We said that when there is a prolonged obstruction of the bile ducts, then of course the patient can present with the secondary biliary cirrhosis. Another presentation of choledocholitis is acute calculous cholecystitis, and cholecystitis just means inflammation of the gallbladder, and when the inflammation is as a result of presence of the gallstone, then we refer to that as acute calculous cholecystitis. Remember the word calculi means the presence of a stone within the biliary tree, and when there is inflammation of the gallbladder as a result of the presence of those stones, we refer to that kind of inflammation of the gallbladder to as a calculous cholecystitis. Next slide, Cam. So cholangitis, we say it is a term that is used to refer to as the acute inflammation of the wall of the bile ducts, and it is almost always caused by bacterial infection. We know that the bile ducts are usually sterile. The lumen is not supposed to have any bacteria in them, and when there is a presence of bacteria within the lumen of the bile ducts, then of course that leads to inflammation, and inflammation of the bile ducts is so-called cholangitis. So cholangitis occurs as a result of lesions of obstructing bile flow, and most of the time this could be due to choledocholitis or the presence of the stones within the bile ducts, or sometimes it could be due to surgical reconstruction of the biliary tree. Remember, like even people with the biliary atresia, those people who need the surgical intervention within the biliary tree, eventually it may lead to obstruction of the bile ducts, and hence inflammation of the bile ducts, what I'm referring to as a cholangitis.
How?
So I think now we go to cholecystitis. I hope I'm audible. I'm not talking to myself. Am I audible?
Oh, we can hear you clearly, Doc.
Okay.
Thank
You know,
you.
sometimes with these online lectures,
Yes.
you might be yourself without knowing. So
Exactly.
cholecystitis. And cholecystitis simply means inflammation of the gallbladder. Today we are going to learn very many terms. We say that inflammation of the bile ducts is referred to as a cholangitis, presence of stones within the bile duct, choledocholitis. And now we are talking about cholecystitis. Cholecystitis means is a term that is used for inflammation of the gallbladder. And this inflammation of the gallbladder could be acute, it could be chronic, or sometimes it could be acute superimposed on chronic, or the so-called acute on chronic cholecystitis. Nearly 95% of cases of acute cholecystitis are due to the presence of gallstones. And if you are keen enough, you're going to realize that most of the pathology we are going to talk about within the extrahepatic biliary tree, either within the gall, within the bile ducts, or within the gallbladder. Most of them, they are always initiated by the presence of the gallstones. And we are saying that in most cases, acute cholecystitis is actually initiated by the presence of gallstones within the gallbladder. And we are saying that 95% of the cases of acute cholecystitis is as a result of presence of the gallstones. So only 5% of cases of cholecystitis are due to other causes other than the presence of the gallstones.
Honestly, maybe gallstones.
Gallstones, you can call them gallstones, gallstones, so long as you know how to spell the word. So acute calculus cholecystitis, and we have said that these refer to acute inflammation of the gallbladder, and we have said that in 95% of cases there is always the presence of gallstones, and when the inflammation is a result of presence of the gallstones, then we refer to that as acute calculus cholecystitis. Remember, gallstones are also referred to as calculi, and that is why we are talking about acute calculus cholecystitis. This is due to the presence of the gallstones within the gallbladder. And most of the time, the gallstones will precipitate acute cholecystitis, especially when the gallstones are small enough and they can be able to, actually be able to go to the gallbladder neck and the cystic duct. So this is very important. Remember that when the gallstone is within the gallbladder itself, most of the time they won't cause inflammation of the gallbladder. The stones will precipitate acute cholecystitis when they cause obstruction. That is when they are able to go to either the gallbladder neck or the cystic duct. And we are saying that this acute inflammation is as a result of obstruction. Remember, if the stone is just within the gallbladder, the gallbladder is a big sac. So when the stone is just within the gallbladder, it won't cause any obstruction. Obstruction will only occur when the stones are small enough and they can be able to flow with the bile to the gallbladder neck or to the cystic duct. And when they do this, then of course they cause obstruction, and eventually the patient present with acute cholecystitis. And that is why the bigger the stone, the more harmless the stone, because the bigger the stone, a big stone will never leave the gallbladder, since it is unable to pass to the gallbladder neck or to the cystic duct, and hence the big stones will never cause obstruction. The small stones are the ones which cause obstruction, because they may be able to pass to the bile ducts. So acute calculous cholecystitis is the most common major complication of gallstones, and it is one of the most common reasons for emergency cholecystectomy. When patients present with the, of course, when they present with the acute cholecystitis, the management is that an operation has to be done and the gallbladder has to be removed, and that is what we refer to as cholecystectomy. Of course, cholecystitis is one of the causes of acute abdomen. The patient will present with the abdominal pain of acute onset or sudden onset, and sometimes the pain can be very severe. And the only management that can be given to the patient presenting with acute cholecystitis is that it has to be managed with the emergency cholecystectomy. And we are saying that as a result of presence of these gallstones with the acute cholecystitis, then this is one of the causes of, or this is one of the indications of emergency cholecystectomy or emergency removal of the gallbladder. So we have then what we refer to as the acute non-calculous cholecystitis or acute acalculous cholecystitis. So it is either acute non-calculous or the acute acalculous cholecystitis. And it has been noted that 5 to 12% of gallbladders removed for acute cholecystitis contain no stones. And when there is no stone involved in precipitation of acute cholecystitis, then this is what we are referring to as acute non-calculous cholecystitis or acute acalculous cholecystitis. Acute non-calculous or acute acalculous cholecystitis will occur in very ill patients, in patients who are severely ill, patients who are very, very sick. And examples of patients that will present with acute acalculous cholecystitis are, for example, patients who have undergone major surgery, and it doesn't have to be necessarily an operation of either the gallbladder or the biliary tree. It can be any other form of major surgery, like, for example, total hip replacement. So patients who have undergone a major surgery may present with acute acalculous cholecystitis. Patients with severe trauma, like, for example, motor vehicle accident, may present with the acute acalculous cholecystitis. Patients with severe burns, these are burns involving high total body surface area. And when they have these severe burns, they may present with acute calculus cholecystitis, patients with sepsis, like for example, patients with septicemia may present with acute non-calculus cholecystitis. So the most important point to take home is that patients who get acute calculus cholecystitis are severely ill patients. Severely ill patients, and the illness they have do not have to be necessarily diseases of the biliary system. It could be any of the other serious illness within other sites within the body. So what are some of the explanations of acute calculus cholecystitis? And these are just postulations because people do not understand how people who are severely ill get this form of cholecystitis. And the postulation is that it could be due to dehydration. So patients who are dehydrated, remember, patients who are severely ill with dehydration, patients who have undergone major surgeries, patients with severe burns may present with dehydration. So people think that dehydration could be the one that initiates acute calculus cholecystitis. Gallbladder stasis and sludging. This is just one of the explanation about acute calculus cholecystitis. Vascular compromise. And when I talk about vascular compromise, patients who have who are presenting with shock. You know that severely ill patients may present with shock, especially patients with septicemia. Patients with severe burns may present with shock and therefore vascular compromise. And the other explanation is that the acute calculus cholecystitis may be explained by bacterial contamination of the biliary tree in patients who are severely ill. So we can go to the next slide. Now we talk a bit about chronic cholecystitis. And chronic cholecystitis may be a complication of repeated bouts of acute cholecystitis. So you can imagine a patient who has gallstones and has repeated bouts of acute cholecystitis, and they may eventually get chronic cholecystitis, but you'll find that is in most instances, the patients who get chronic cholecystitis have never had any bout of acute cholecystitis. So these are patients who may have no history of acute attacks of acute cholecystitis, and they are known just to develop chronic cholecystitis with no history of acute cholecystitis. Like acute cholecystitis, it is almost always associated with the presence of gallstones. Remember, I told you that what we are going to learn about the biliary tree, nearly all the pathologies we are going to learn about the biliary tree, if you are asked the cause or even a disease of the biliary tree, and when I talk about the biliary tree, I mean the gallbladder and the bile ducts. So any pathology of the gallbladder and the biliary tree, if you ask the cause and you say gallstones, you'll always be right, because most of these pathology of the gallbladder and the bile ducts, they'll always be associated with the presence of gallstones. So somebody saying that he needs some explanation what I mean acute superimposed on chronic. And acute superimposed on chronic is when a patient has been having a chronic cholecystitis, or the patient starts with chronic cholecystitis, and then eventually they get acute bout of acute cholecystitis. So this is a patient who has been having chronic cholecystitis with no acute cholecystitis, then suddenly or acutely they have a sudden onset of acute cholecystitis. That is what I'm calling acute superimposed on chronic. So there are patients who start with chronic cholecystitis and then they have acute bouts of cholecystitis, and that is what I'm referring to as acute superimposed on chronic cholecystitis. Then we go to cholerythiasis, and cholerythiasis means the presence of gallstones within the gallbladder. When the stones are within the gallbladder, we refer to that as cholerythiasis. So when you hear somebody talk of cholerythiasis, it means the presence of stones within the gallbladder. And we know that we have two types of gallstones, and the two types of gallstones is what we refer to as the cholesterol stones, and then the other type of gallstones is what we call the pigment stones. So if you are asked the two types of gallstones, we have the cholesterol stones and then the pigment stones. So broadly, that is how we divide them. But we know that most of the time you won't find a pure cholesterol stone. You'll always find that even a cholesterol stone will have some level of pigment. So what I'm saying is that it is very unusual for a stone to be completely made up of crystalline cholesterol stone, or made up just of cholesterol. And what we have most of the time is a stone that have many other components, including calcium, including pigment. And it is very unusual to find a pure cholesterol stone. At the same time, it is very unusual to find a pure pigment stone. And most of the time you will find that these stones will have other components. It will have cholesterol, and then it will have a mixture of pigment. And when I talk about pigment, is bilirubin. It will have calcium. So pure stones are unusual. Most of the time, what we have is a combined stones. And of course, we know that cholesterol stones are more common than pigment stones, as we are going to see as we move on with the lecture. So the pathogenesis and risk factors, and we know that cholesterol, the elimination of cholesterol within the body occurs significantly only within the bile salts. So the cholesterol will always be eliminated within the biliary system, and it is the only significant pathway for elimination of cholesterol within the body. There is no any other way that cholesterol can be eliminated significantly within the body except within the biliary tree. And it is usually eliminated as free cholesterol within the biliary system or as bile salts. We know that cholesterol is usually water insoluble. So pure cholesterol is water insoluble. And it is usually rendered to be water soluble by aggregation with bile salts and lecithins. And we know that the bile salts and lecithins are usually secreted to the bile. And these bile salts are the ones which render this cholesterol to be water soluble, because cholesterol in its natural form is usually water insoluble, and it is rendered to be water soluble by aggregation with the bile salts. So what happened in the formation of gallstones? And in cases where the cholesterol concentration within the bile exceed the solubilizing capacity of the bile, we say that the bile salts are the ones which render cholesterol to be water soluble. But if the cholesterol concentration within the bile is so high, or what we refer to as the supersaturation of bile with the cholesterol, then the cholesterol can no longer remain dispersed, and it ends up being, but there is a nucleation into solid cholesterol monohydrate crystals. And these cholesterol monohydrate crystals are the so-called cholesterol gallstones. So when the cholesterol concentration is very high within the bile, and then it exceeds the capability of the bile salts to make it to be water soluble, and since we know that cholesterol itself is water insoluble, then of course when the concentration is very high, then of course there is formation of these cholesterol monohydrate crystals within the biliary system. So cholesterol gallstone formation involves these four occurring processes, And the first one is that there is a supersaturation of bile with cholesterol, and then establishment of the nucleation sites by the microprecipitates of calcium salts. And then there is bile stasis. And as we are going to see, bile stasis is one of the risk factors to gallstone formation within the biliary system. And then eventually there is a secretion of the mucus. And this mucus trap the crystals together, and it enhances the aggregation of these crystals into cholesterol stones. What about the pigment stones? That is much about the cholesterol stones. And the pigment stones occurs when there is presence of unconjugated bilirubin in the biliary tree. And this increase the likelihood of pigment stone formation. And you'll always find pigment stones occurring in patients with hemolytic anemias. Like, for example, they are very common in patients with sickle cell anemia. So patients with hemolytic anemias, and you know that sickle cell anemia is one of the examples of hemolytic anemias. And of course, you know that bilirubin is formed from the products of breakdown of hemoglobin in hemolytic anemias. And that is why patients with hemolytic anemia are more predisposed to formation of the pigment stones. The other situation where you will find a patient getting pigment stones is where there is an infection of the biliary tract. So there are these two conditions where there is a hemolysis, and then where there is infection of the biliary tract. You will find that there will be formation of the pigment stones. So the precipitate in the pigment stones are usually the insoluble calcium bilirubinate salt. And the major component in the pigment stone, of course, is bilirubin as a result of breakdown of hemoglobin. So what are some of the risk factors to gallstone formation? And this is mainly the cholesterol stones. So what are some of the factors that predispose individuals to formation of cholesterol stones? And let me begin by saying that 80% of individuals with gallstones, there is no identifying risk factor. There is no identifying risk factor other than the age and gender. The age and gender of the patient. So in most of those patients who are found to have gallstones, you won't find any other risk factor other than from the age and gender. And we know that females are the commonest to get these cholesterol stones. At the same time, females of increasing age, older females, are the ones who get these cholesterol stones. And in most of these patients, you won't find any other risk factor apart from older females. We know that cholesterol stones again are more common in the Western world, although they are becoming commoner even in the third world countries because of course of the change in lifestyle, change in lifestyle, diet, and it is not unusual to find patients even in the third world countries getting cholesterol stones. But we know that cholesterol stones are generally a disease of the Western world. And of course, another risk factor, which I've already said, is advancing age, female sex hormones. I've already said that these stones are more common in females. They are more common in the female gender. On patients with oral contraceptives, of course, oral contraceptives are only taken by females, unless there are males who take oral contraceptives, which I'm not aware of. So females who are on oral contraceptives, of course, are more predisposed to cholesterol stones. Patients who are pregnant or pregnancy, obese patients or patients with obesity, patients where there is rapid weight reduction, patients where there is gallbladder stasis, patients with inborn disorders of bile acid metabolism, and in patients with hyperlipidemic syndromes or patients with hyperlipidemia. So those patients with hyperlipidemia, of course, they may present with gallstones. Then what are the risk factors to pigment stone formation? And the pigment stones are more common in the Asian community than in the Western communities, unlike the cholesterol stones. They're also more common in rural more than the urban setup. And we say that the predisposing factors are chronic hemolytic anemias, and then biliary infection. That is an infection of the biliary tree at any level will, of course, predispose to pigment stone formation. Then we have the gastrointestinal disorders, like in cases of Crohn's disease, in cases of ileal resection and bypass, in cases of cystic fibrosis and pancreatic insufficiency. And the explanation of this pigment stone formation in patients with gastrointestinal disorders is, of course, you know that there is that circulation, there is an enterohepatic circulation of the bile salts or the bile acids. And of course, when there is that lack of that enterohepatic circulation, then of course that will predispose to pigment stone formation. Next slide. So we look at the morphology. So cholesterol stones arise exclusively within the gallbladder, and they consist of 50 to 100% cholesterol. And I told you that it is very unusual to find pure stones. Most of the time you will find that the cholesterol stone will have other component apart from the cholesterol. So pure cholesterol stones are usually pale yellow, and when there is increasing proportion of calcium carbonate, phosphate, and bilirubin, then the stones become gray-white, and some of them may have a black discoloration. This is a result of these other components that may be found in some of these cholesterol stones. Again, a very important point is that most cholesterol stones are radiolucent. What that means is that if you are to take a plain abdominal X-ray, you may not be able to see cholesterol stones because they are radiolucent. They are not radiopaque. So if you are just to take a plain abdominal X-ray, then even if a patient has a cholesterol stone, you may not be able to see them because they are, most of them are radiolucent. But with increasing amount of calcium carbonate, the stone may be rendered to be radiopaque. So as the amount of calcium carbonate increases within the stone, then of course the stone is rendered to be radio opaque, and you may be able to see them on plain abdominal X-ray. But we know that pure cholesterol stones, you may not be able to see them with a plain abdominal X-ray. What about the pigment stones? A pigment stone may arise anywhere within the biliary tree. So somebody is asking what will be the best imaging modality for cholesterol stones. And of course, we have ultrasound, which is good in diagnosis of cholesterol stones. So if you are to do ultrasound, you will be able to pick pure cholesterol stones. But if you do plain X-rays, you may not be able to see them. But ultrasound, of course, you will be able to pick the cholesterol stones. So pigment stones may arise anywhere within the biliary tree. We say that the cholesterol stones occur exclusively within the gallbladder. So the black stone, pigment stones are found within the sterile gallbladder bile, while the brown stones are found in infected intrahepatic or extrahepatic bile ducts. And of course, that goes back to what I told you, that what predisposes to patients getting pigment stones is one, hemolytic anemia, the other one is infection. And of course, when there is infection, there is formation of these pigment stones within the biliary tree. So pigment stones contain calcium salts of unconjugated bilirubin, and they may have less amounts of other calcium salts, mucin, glycoprotein, and cholesterol. So again, I say that it is hard to find a pure stone. Most of them will have many more other components apart from the just the cholesterol or the bilirubin. So most of them will be combined stones. So black stones are usually small, and they are usually present in large quantities, and they crumble easily. So the way we normally find these black stones is that they are usually very many, and you find them as a sand. You find them as because they are small, you find them as just grains of sand within the biliary tree or within the gallbladder. Cholesterol stones, most of the time you'll find them as a single large stone. So cholesterol stones, most of the time single, and they are usually very large and found within the gallbladder. But the pigment stones or the black stones are usually many and small, and usually found, they resemble sand. So I can see somebody asking a question about cholesterol stones, but I'm not getting what the person is really asking about the cholesterol stones. So brown stones again tend to be single or few in number. And because of the presence of calcium carbonate and phosphate, 50% to 75% of black stones are radio opaque. So you are able to visualize them in a plain abdominal X-ray. So when you do a plain abdominal X-ray, you may be able to visualize these pigment stones, because we know that 50 to 75% of these black stones are usually radio opaque. And that is as much as I wanted to talk about the gallstones. That is not to say that that is everything about gallstones. That is a summary about gallstones. As you can see, some of these lectures are very long. We have not even started on the pathology of the pancreas. We are still on the pathology of the extrahepatic biliary tree. And then finally, we go to the tumors of the extrahepatic biliary tree. So, and we can start with the carcinoma of the gallbladder. And let me begin by saying that the carcinoma of the gallbladder is slightly more common in women and occur most frequently in the 7th decade of life. Some clarification to make is that tumors appear to occur in slightly young patients in our setting than in the Western world. Remember, most of the literature we refer to is the literature in the Western world, and we know that most of these tumors will tend to occur earlier than the 7th decade. It is not unusual to find the people in their 50s getting carcinoma of the gallbladder. So these tumors are rarely discovered at a resectable stage, and the mean 5-year survival is 5%. So by the time these tumors are discovered, they have already progressed, and most of the time they already have they'll have spread to other areas where they have metastasis, and that is why by the time they are discovered, the carcinoma of the gallbladder, by the time they are discovered, they are usually tumors of advanced age, and that is why the 5-year survival rate is very poor after they have been diagnosed. After they have been diagnosed in 100 patients, only 5% of them, in 100 patients, only 5% of them will be living within the 5 years. 95 in 100 will already be dead within a duration of 5 years. And I said that if you are to say gallbladder in any form of pathology of the biliary tree, you'll be right. And we are saying that in 60 to 90% of cases of patients with carcinoma of the gallbladder, they will have gallstones. There are parasites that have been associated with the carcinoma of the gallbladder. Go and check which parasites are usually associated with carcinoma of the gallbladder. But we know that there are some parasites that are associated with carcinoma of the gallbladder. So in patients with stones or infectious agents within the gallbladder, what happens is that with the presence of gallstones within the gallbladder, then there is recurrent trauma as a result of the presence of these gallstones. And of course, with chronic inflammation, we say that these gallstones will initiate inflammation of the gallbladder. So when there is this chronic inflammation, then of course, with the healing and repair, of course, you know, with chronic inflammation, there is tissue destruction, and then there is repair. And as a result of this ongoing process of inflammation, tissue destruction, and then repair, there's bound to be mutations. Mutations occur as a result of this high turnover of the epithelial cells of the gallbladder. As a result of this high turnover, of course, there is mutations, and these mutations are the one which eventually leads to development of carcinoma of the gallbladder. Then we have cholangiocarcinoma, and cholangiocarcinoma are adenocarcinomas with the biliary differentiation arising from the cholangiocytes in the bile duct. And of course, you know that the bile ducts, we have both the intrahepatic and extrahepatic bile ducts. And when a tumor develops within the bile ducts, whether they are intrahepatic or extrahepatic, we refer to that tumor as a cholangiocarcinoma. So extrahepatic cholangiocarcinomas constitute approximately 2/3 of the tumor. So cholangiocarcinomas involving the extrahepatic bile ducts are more common than those involving the intrahepatic bile ducts. And they may develop at the hilum, or the level of the hilum, and when they develop at the level of the hilum, those are the ones which are referred to as the Klatskin tumors. And I think that is the much I wanted to talk about tumors or pathology of the extrahepatic biliary tree. And I'm telling you that these are summarized kind of a lecture, and you will need to go and read about pathology of the extrahepatic bile duct. But that's the much I wanted to talk about today. And now we go to the pathology of the pancreas.
Sure.
So we can go to the diseases of the pathology of the pancreas.
Yeah, we can.
Yeah, I can see you have already projected that.
Mm-hmm.
We can take a break of 2 minutes. Maybe. Yes?
Yes, of course, Doc. We can
2 minutes. A break of
no
2
problem.
minutes. Yeah.
Okay.
So I think now we can start on the pathology of the pancreas. And what we are going to talk about today is the pathology of the exocrine. So somebody is asking, what's the difference between choledochoritis and calculus cholecystitis? I said that choledochoritis is the presence of a stone within the bile ducts. Remember, choledochoritis do not mean inflammation. So inflammation do not necessarily have to be there in the choledochoritis. So choledochoritis is just the presence of stone within the bile ducts. When there is inflammation, that is the time we use terms like cholangitis. If the inflammation is within the bile ducts, we use the word cholangitis. And if the inflammation is within the gallbladder, then we use the word cholecystitis. So you have to be familiar with the terminology. Choledochoritis, presence of a stone within the bile ducts. When the stone is within the gallbladder, we refer to that as cholerithiasis. When there is inflammation of the bile ducts, that's cholangitis. And when there is inflammation of the gallbladder, we refer to that as a cholecystitis. So you have to be familiar with the terminology. So today we are going to talk about a pathology of the exocrine pancreas. Could you please explain how chronic cholecystitis? Ask that again. I think it has gone before. Somebody is asking about cholecystitis and something else. I didn't see that very well. So I think you're going to ask the question again as we move
The whole
along.
question.
Yes,
Can
what
you
was the
read
question?
The whole question.
Kindly
Could
read
you
for
please
me.
explain how chronic cholecystitis can happen without repeated bouts of acute cholecystitis?
Oh, how chronic cholecystitis can happen without repeated bouts of acute cholecystitis. Remember, I'm sure you are taught about inflammation when you're in your third year. And when you talk about acute inflammation, or when we talk about acute cholecystitis, this is cholecystitis of acute or sudden onset. And most of the cells that are involved in acute cholecystitis, you know, it is an acute suppurative inflammatory process, which is most of the time the cells that are involved are the neutrophil polymorphs. But in certain cases of chronic cholecystitis, the patient is not known to have had any form of an acute inflammatory process. And what we notice that they will end up by having a chronic inflammation. You just find that within the wall of the gallbladder, there is a chronic inflammatory cells. We know that the chronic cholecystitis, the players in chronic cholecystitis is the lymphocytes, plasma cells, and even macrophages. So in some cases of chronic cholecystitis, the patient will never have any history of acute cholecystitis. So they'll progress directly to chronic cholecystitis with no history of acute cholecystitis. I think I don't know whether that makes any sense to you. So we go to pathology of the exocrine pancreas because of the time. Remember, we are going to talk about diseases of the endocrine pancreas another day. Today we are talking about exocrine. Remember, the pancreas has both the exocrine and endocrine functions. And you note that now we are talking about, you are learning about disorders of the GIT. And the part of the pancreas that is important in the GIT is the exocrine pancreas. So we start, and I've shown there are pictures of normal pancreas, how it looks like. And, you know, the pancreas has the exocrine part. And the exocrine part is composed of the pancreatic acini. And then we have the endocrine pancreas. And the endocrine pancreas is the ones that is involved in the production of the hormone of the some hormones like insulin. Insulin is very important, and it is produced by the endocrine part of the pancreas. So we directly go to the congenital anomalies of the exocrine pancreas, and the first one is agenesis. And agenesis means that there is absence, or people are born with no pancreas. And when people are born with no pancreas, we say that they have a pancreatic agenesis. Then we have a pancreatic divisum. And if you remember your embryology lectures, you are told that the pancreas develop from two sides. And then after some time, there is a fusion of these two sides of development of the pancreas. Sometimes these fusions do not occur. In rare instances, you will find that there is no fusion, and the two sides of pancreatic development occurs as two separate areas of development, and this is when we refer to this as a pancreatic divisum, and or when there is division in the development of the pancreas as a congenital malformation. And then we have annular pancreas. Annular pancreas is a situation whereby there's a formation of a annular ring around the duodenum. Instead of the pancreas developing as with the head, the body, and tail, it develops as an annular ring around the duodenum. And when there is this annular ring around the duodenum, then that is what we refer to as an annular pancreas. Then we have a heterotopic pancreatic tissue, and the heterotopic, from your knowledge in medicine, means ectopic sites. And you know, sometimes you will find the pancreatic tissue within ectopic sites, and sometimes you will find the pancreatic tissue within the stomach. Sometimes pancreatic tissue within a diverticulum. And when we have this ectopic pancreatic tissue, and ectopic means when the pancreatic tissue is found in abnormal sites, then we talk about heterotopic pancreatic tissue. And then we have cysts, and these can be true congenital cysts, or sometimes false cysts. And when they are false cysts, that is what we refer to as a pseudocyst. And sometimes they may be neoplastic cysts. So all these are congenital anomalies of the pancreas. The pictures there, the first one is showing heterotopic pancreas within the stomach. So you just find the ectopic pancreatic tissue within the wall of the stomach. And then the other picture is just a higher magnification of the first picture, and that is a heterotopic pancreatic tissue within the stomach. So the other we can go to the next slide. And we have already talked about the simple cysts. the simple cyst occurring as a congenital anomaly within the pancreas. And these simple cysts are usually derived from the duct. The initial thing that happened is that there is a obstruction of the duct, and then there is cystic dilatation of the duct. And then when that happens, of course, there's development of the simple cyst of the pancreas. And these simple cysts will range from microscopic to cysts that are 3 to 5 centimeters in diameter. So some of the cysts are very small, and you can only be able to see them microscopically. Others are large, up to 5 centimeters, and you may be able to see them grossly. These cysts are usually lined by flat cuboidal duct type epithelium, and most of them will be filled with fluid. They are usually solitary and asymptomatic. So you will find them as a solitary pancreatic cyst, and most of them will be asymptomatic. In fact, most of them we see them as incidental findings during autopsies, or when you undergo imaging, like for example, you undergo a CT scan of the abdomen or MRI of the abdomen, and they are seen as just incidental findings. They are cysts that have never caused the patient any problem, and they are just asymptomatic, and they are just found as incidental findings. Pancreatic cyst may be associated with other diseases, like in polycystic kidney disease. And in polycystic kidney disease, you may find the multiple cysts within the kidney, and you may find cysts within the liver. At the same time, there could be pancreatic cyst in this condition of polycystic kidney disease. Then we have another congenital disease, or the so-called von Hippel-Lindau disease. And in this disease, you find cysts within the pancreas, within the liver, and again the kidney. And then in this disease, the other remarkable finding is that you may find central nervous system angiomas. So the next slide shows you how a simple cyst, simple pancreatic cyst look like. And they are usually lined by simple cuboidal epithelium. That is how they look grossly. And then if you are to do microscopy, that is the picture on your left, on the left side. It's a microscopic appearance. And the one on the right side is a gross appearance of a simple congenital cyst of the pancreas. So that's much about congenital anomalies of the pancreas. And now we can go to the inflammation. The next slide is inflammation of the pancreas. And if there is one condition that I'm sure for most of you who are going to become doctors eventually as a result of those who will be able to go through the training and become doctors, I'm sure in one there'll be time when you're going to come across patients with acute pancreatitis. So when it comes to pancreatic pathology, inflammation is very, very important because we know that it's common. And then the other thing about acute pancreatitis is that it is a very serious disease. And if you're not aware about it, most doctors will either miss it, and then if you miss it, the patient will end up dying because most of the time it's a very serious disease. The patients are very, very, very sick. And if you're going to miss it, a good percentage of the patients will eventually die. So acute pancreatitis is very, very important. And I think it is the most important when we talk about pathology of the pancreas. Acute pancreatitis must be the most important. And acute pancreatitis just means autodigestion and inflammation of the pancreas. We know that the pancreas produce enzymes that are important in digestion. Can you have gone to the beginning? I think we are already in the inflammation. Can you move the slides to inflammation so that people can be able to see? Yeah. So we are saying that acute inflammation is acute pancreatitis is acute inflammation of the pancreas. And we know that when there is acute inflammation of the pancreas, one of the things that happens is that instead of the enzymes that are produced being passed to the small intestines or to the duodenum so that they can assist in digestion of the food material taken, these enzymes digest the pancreas itself. So the usual thing that happens is that these enzymes that are produced by the pancreas, they're usually passed by the ducts to the duodenum so that they can help in the digestion of the food material within the GIT. But we know that in acute pancreatitis, what happens is that instead of these enzymes being passed to the small intestines for digestion of the food material taken, these enzymes auto-digest the pancreas itself. And the enzymes are produced and then they digest the pancreatic tissue itself instead of digesting the food material that have been taken within the GIT. So what are the causes of acute pancreatitis? And the commonest cause of acute pancreatitis is alcoholism or acute alcohol ingestion. And you'd always get that history. For patients who are presenting with acute pancreatitis, you'll always find, if you take the history, you'll always find that there will always be history of acute heavy alcohol ingestion. So the commonest cause of acute pancreatitis is actually acute alcohol ingestion. The other cause of acute pancreatitis is obstruction. And we said, we talked about gallstones. Remember the drainage of bile and the pancreatic secretions to the duodenum is through the sphincter of Oddi. And of course, you know that the pancreatic duct, at the same time, the common bile duct. At one point, they fuse to form one duct. And if there is obstruction of this duct by the gallstone, of course, the patient may present with acute pancreatitis. So gallstones is another cause of obstruction of the pancreatic duct, hence leading to acute pancreatitis. There could be other causes of obstruction like tumors, scarring, congenital abnormality. So all those will cause obstruction. And as a result of this obstruction, the patient may present with acute pancreatitis. So what are the mechanisms in acute pancreatitis? And the mechanisms involved in initiation of acute pancreatitis, we have first duct obstruction. The other mechanism, and remember when I talk about the mechanism, I'm talking about the pathogenesis. What are the pathogenesis of acute pancreatitis? And one of them is duct obstruction. The next one is acinar cell injury. When there is injury to the acinar cells, then of course that may result in acute pancreatitis. And that is how acute alcohol ingestion initiates acute pancreatitis. We know that alcohol is a form of poison. And when there is exposure of the acinar cells of the pancreas to to high level of alcohol, then that may lead to acid cell injury, and hence resulting in acute pancreatitis. The other pathogenesis or mechanism is defective intracellular transport within the acinar cells, and therefore presenting with acute pancreatitis. What is the pathology of acute pancreatitis, or what happens in acute pancreatitis? And one of the changes that occur in acute pancreatitis is that there is edema of the pancreas itself, and this edema occurs as a result of the microvascular leakage. Remember what you learned in acute inflammation, and one of the features of acute inflammation is acute, but there is an endothelial leakage. So as a result of this endothelial leakage, there is leakage of fluid interstitial space, and that leads, of course, to edema. There is increased permeability of the small blood vessels, and as a result of this increased permeability, and then of course that leads to net movement of fluid from the intravascular compartment to the interstitial space, hence leading to edema. Then of course there is fat necrosis and saponification, and this is as a result of release of the lipolytic enzymes. I remember I said that in acute pancreatitis, what happens is that instead of the enzymes being taken to the small intestines for digestion, in acute pancreatitis, these enzymes actually auto-digest the organ itself. This, as a result of this auto-digestion of the pancreas, then there is fat necrosis and saponification. There is also interstitial hemorrhage, and this is as a result of destruction of the blood vessel walls. And as a result of this destruction of the blood vessel wall, of course, there is hemorrhage. Parenchymal necrosis, again, this is as a result of a release of proteolytic enzymes that are produced within the pancreas. And then, of course, in acute pancreatitis, there is acute inflammation. And this acute inflammation is in form of infiltration of the organ by acute inflammatory cells. And of course, you know that the acute inflammatory cells are the neutrophil polymorphs. So in mild cases of acute pancreatitis, when it is mild, the pancreas will have edema, there will be fat necrosis. And when I talk about fat necrosis, is a fat necrosis of the fat around the pancreas. At the same time, there could be necrosis of the omental fat and the mesenteric fat within the abdomen. And then there could be saponification. This is in mild cases. And in severe cases, there is necrosis of the acinar cell duct, and there could even be necrosis of the islets of Langerhans. Remember, the islet of the Langerhans is the endocrine pancreas. Again, fat necrosis, and this may occur within and outside the abdomen. And again, necrosis of the blood vessels with hemorrhage. This is in the severe cases of acute pancreatitis. So that is how an organ or a pancreas with acute pancreatitis appear. There is fat necrosis. There is parenchymal necrosis as a result of release of both lipolytic and proteolytic enzymes from the pancreas, and hence causing autodigestion of the pancreatic tissue. The next slide is necrosis of the pancreatic parenchyma as a result of autodigestion. And if you look at the picture on the right hand side where there is normal pancreas, those are the normal pancreatic acini. And then on the lower left, you can see there is a necrosis of the pancreatic tissue. And then in the next slide, there is a fat necrosis. And in most cases of acute pancreatitis, even when we are doing postmortems, when you open the abdomen, you'd always find the fat necrosis, both the omental fat, the fat around the pancreas, and at the same time, the mesenteric fat. There will always be fat necrosis. And grossly, that is how ugly the pancreas look like when it has acute necrotizing pancreatitis. This is in the severe cases. The pancreas will have a lot of hemorrhage. It will appear black because of the hemorrhage. And then, of course, it will appear large because of the edema. There'll be fat necrosis. So that is how pancreas with the acute necrotizing pancreatitis look like. You can never miss it even in cases of postmortems. Now we go to chronic pancreatitis. And recurrent bouts of inflammation of the pancreas leads to loss of the pancreatic parenchyma and replacement by fibrosis. So when this inflammatory process is ongoing for a long period of time, then of course there is loss of the pancreatic parenchymal tissue, and this is replaced by fibrous tissue. And this is what happens in chronic inflammation. What you are told when you are being taught your chronic inflammation, I'm sure you are told that there is tissue destruction, and the tissue that is being destroyed is the pancreatic tissue. And after the destruction of the tissue, there is healing by fibrosis. So in chronic pancreatitis, there is loss of the pancreatic parenchymal tissue, and this is a process that happens over a long period of time. And this pancreatic parenchymal tissue is replaced by fibrous tissue. So what are some of the causes of chronic pancreatitis? And we have alcohol abuse. Again, alcohol is a major player in the pathology of the pancreas. Cases of hypercalcemia and hyperlipoproteinemia. In patients with the pancreas divisum, we say that pancreatic divisum is one of the congenital anomaly of the pancreas. So those patients who have a pancreas divisum, they may present with chronic pancreatitis. Hereditary pancreatitis. There is a condition which is referred to as a hereditary pancreatitis. And those patients with hereditary pancreatitis, of course, present with the chronic form of pancreatitis. So how do the pancreas with the chronic pancreatitis look like? And the first change you are going to see on the pancreas with the chronic pancreatitis is that there will be loss of the lobular appearance or loss of lobulation of the pancreas. And this is as a result of the loss of the exocrine tissue of the pancreas. The other thing that is going to happen to the pancreas is that there'll be fibrosis. And we say that as a result of the loss of the pancreatic parenchymal tissue, there is healing with fibrosis. There is replacement of the pancreatic parenchymal tissue by fibrous tissue. The pancreas will be of reduced size as a result of this loss of pancreatic tissue, at the same time fibrosis. there will be reduction in the size of the pancreas. And then, of course, when you look at the pancreas under the microscope or the histology, you will find that there will be features of chronic inflammation in cases of chronic pancreatitis. There will also be destruction of the duct, and the ducts will be dilated. The ducts will be dilated, and the patient or the pancreas may have what we call the cyst or the pseudocysts. And the pseudocysts will occur in about 25% of patients with chronic pancreatitis. So the next slide shows you how a pancreas with the chronic pancreatitis look like. On the right hand side, we have the normal pancreas, and then on the right side, left normal pancreas, and then right pancreas with the chronic pancreatitis. And then in the next slide, there is a on the left lower side, there is a pancreas histology of a pancreas with the chronic pancreatitis. And then on the right side, there is normal pancreas. And on histology, of course, it demonstrates loss of pancreatic tissue, at the same time fibrosis, and also the presence of the chronic inflammatory cell infiltrate within the pancreatic tissue. So what are some of the complications of acute pancreatitis? Again, very, very, very important. You are going to see patients who have these complications of acute pancreatitis. And one of the commonest complication of acute pancreatitis is shock. You know, the patient will present with shock, and they will present with shock. Just means that the blood pressure will be very low because of vasodilatation. As a result of this vasodilatation, the patient will present with low blood pressure, and they will present in shock. I'm sure when I talk about shock, you know what I'm talking about. They may have multiple organ failure, those who present with acute pancreatitis. They may present with the disseminated intravascular coagulation. They may eventually get pancreatic abscess. They may have a pancreatic pseudocyst, or even sometimes they may present with duodenal obstruction as a result of inflammation around that site. You know that the pancreas is usually attached to the duodenum, and as a result of inflammation of the pancreas, there may be inflammation around that area, and the patient may eventually present with a duodenal obstruction. What are some of the complications of chronic pancreatitis? And some of the complications that patients with the chronic pancreatitis may have, we have a duct obstruction, again pseudocysts. These patients may present with malabsorption. Remember, with the chronic pancreatitis, there is loss of pancreatic parenchymal tissue. And as a result of the loss of this pancreatic parenchymal tissue, there is a lack of production of proteolytic enzymes that are important in the digestion of food, and the patient may present with malabsorption. The other complication of chronic pancreatitis is secondary diabetes, and these patients are presenting with diabetes because we know that with the chronic pancreatitis there may even be destruction of the islet of Langerhans, or islet of Langerhans, and we know that is where the insulin is produced. And when there is destruction of the islet of Langerhans, of course, there'll be lack of production of the insulin, and the patient may present with the secondary diabetes mellitus. Somebody saying I explained why patients with acute pancreatitis may present with disseminated intravascular coagulation. And what happens in the acute pancreatitis is that, remember the predisposition to coagulation. One of the predisposing factors to coagulation is when there is a vessel wall destruction. And what happens is that as a result of this acute pancreatitis, there may be destruction of some of the vessels. And when there is a vessel destruction or vessel wall destruction, then of course these may present with the DIC or disseminated intravascular coagulation. Some of these lectures are very long, and you may have to bear with me. I'm nearly finishing. Let's talk briefly about pancreatic pseudocysts. And we have seen that pancreatic pseudocysts may present as a complication of both acute and chronic pancreatitis. And pancreatic pseudocysts, as the name may indicate, pseudocysts mean four cysts. And a four cyst is a cyst with no epithelial lining. So when there is a cyst without epithelial lining, that's a four cyst, and that is what I'm calling a pancreatic pseudocyst. And the pancreatic pseudocysts are just localized collection of pancreatic secretions. All of them, virtually all of them, arise from a bout of acute or chronic pancreatitis. They are not true cysts. They are four cysts because they lack epithelial lining. And what line the pancreatic pseudocysts are macrophages and fibrotic tissue. So they lack epithelial lining. And they must be differentiated from pancreatic abscesses because we know that pancreatic abscesses is collection of neutrophils as a result of necrosis of the pancreatic parenchyma. So you have to differentiate between a pancreatic pseudocyst and a pancreatic abscess. So the next picture shows you how a pancreatic pseudocyst look like grossly. So that is a pancreatic pseudocyst. That's how it appears grossly. And the next picture is how a pancreatic pseudocyst look like on histology. It has no epithelial lining. What it has is the macrophages on the surface with no epithelial lining. So that is a pancreatic pseudocyst with no epithelial lining. So in the other picture, I'm trying to show you the difference between a pancreatic pseudocyst and a true congenital cyst of the pancreas. The one on the lower right side is a true congenital cyst of the pancreas, and you can see it has an epithelial lining. And then the other cyst is a pseudocyst, and it lacks an epithelial lining, and that's why we are calling it a pseudocyst. So from inflammation, we go to the tumors or neoplasia of the exocrine pancreas. And the most common tumor of the exocrine pancreas is a ductal adenocarcinoma. You are going to find a ductal adenocarcinoma of the breast also. You should not confuse them. We have both ductal adenocarcinoma of the pancreas and ductal adenocarcinoma of the breast. Today we are talking about the pancreas, and the commonest malignant tumor of the pancreas is ductal adenocarcinoma. It is the most common neoplasm of the pancreas, and it's common between the age of 60 and 80 years of age. I said that tumors in our setting will occur much earlier than tumors in the Western world. And it is not unusual to find people in their 30s, 40s, 50s getting ductal adenocarcinoma of the pancreas in our setting. Actually, the commonest age group of ductal adenocarcinoma in our setting is maybe the age of 40s and 50s. That is the age that you're going to find most of the cases of ductal adenocarcinoma in our setting, because most of the tumors will occur in a bit young age in our setting than in the Western world. There is a slight male predominance, the ratio being 1:6:1. So it is more common in males than in females. What are some of the risk factors? And the risk factors to ductal adenocarcinoma of the pancreas, one of the most important known risk factor is cigarette smoking. The next one is high fat diet, chronic pancreatitis, and we say that the commonest cause of chronic pancreatitis is actually alcohol ingestion or alcoholism. Patients with diabetes mellitus are also known to eventually get ductal adenocarcinoma. And again, patients who have been exposed to carcinogens. Some carcinogens, they will eventually present with ductal adenocarcinoma. So these are the few known risk factors to ductal adenocarcinoma of the pancreas. Then we have also the genetic risk factors. And a common hereditary risk factor is patients with the BRCA gene mutations. You know that BRCA means breast cancer gene, or patients who have hereditary breast cancer or ovarian cancer, those who have breast cancer gene mutation. Patients with hereditary pancreatitis, and they are more than 50 times more predisposed to ductal adenocarcinoma than the general population. Patients with that syndrome, the Peutz-Jeghers syndrome, and again patients with hereditary non-polyposis colon cancer, or the HNPCC, hereditary non-polyposis colon cancer. What are the clinical features of ductal adenocarcinomas of the pancreas? And the first one, especially if the tumor is affecting the head of the pancreas, the patient will present with a surgical jaundice or painless jaundice. So the patient will present with the surgical jaundice. I know by now you know the difference between the surgical and medical jaundice. And patients with the ductal adenocarcinoma of the pancreas will present with the surgical jaundice. They will also present with abdominal pain, weight loss, and again migratory thrombophlebitis. And another important features of ductal adenocarcinoma is pruritus. So those patients will present with both the surgical jaundice, at the same time they'll present with itchiness. Itchiness is a result of a biliary obstruction. So when there is a biliary obstruction, there is a retention of the bile salts, and the bile salts are the one which cause itchiness. So those patients will present with jaundice, at the same time itchiness of the body. The migratory thrombophlebitis is what is also referred to as Atresia's sign. So what are some of the molecular genetics of the ductal adenocarcinoma? And we have the KRAS point mutations, and these will be found in more than 90% of cases of pancreatic carcinoma. Then we have also tumor suppressor gene mutation, and the tumor suppressor genes we are talking about is the P53, and the P53 mutation is present in more than 60 to 80% of patients with the ductal adenocarcinoma. And then we have the HER2/neu overexpression, and this is present in more than 70% of cases of ductal adenocarcinoma. So how do patients with ductal, or what is the gross pathology of ductal adenocarcinoma? And we know that ductal adenocarcinoma is more common in the head of the pancreas, and it affects the head of the pancreas in 60% of the cases of this form of cancer will occur within the head of the pancreas. 15% will occur in the body of the pancreas, and 5% in the tail of the pancreas. 20% of these tumors will be diffuse, affecting the entire pancreas. And grossly, it appears as a poorly circumscribed mass within the pancreas that is gray-white in color and firm in consistency. So what I've said about the gross presentation is that it will be a poorly circumscribed mass that is gray-white in color and firm in consistency. It can infiltrate the tissues adjacent to the pancreas. And of course, you know, the tissues that are adjacent to the pancreas, it can infiltrate into the duodenum, it can infiltrate into the stomach. So those are the tissues that are adjacent to the pancreas. So what are the histopathologic features of the ductal adenocarcinomas of the pancreas? This tumor usually arises from the ductal epithelium or the ductal epithelium of the pancreas, and that is why they are referred to as the ductal adenocarcinomas of the pancreas. They are usually moderately to poorly differentiated adenocarcinomas. Perineural and angiolymphatic invasion is common. What I mean by perineural is when there is infiltration of the neural tissue, and angiolymphatic is when there is invasion into the vascular and the lymphatic vessels within the pancreas, and almost always associated with chronic pancreatitis. So for those patients where there will be ductal adenocarcinomas, if you look at it microscopically, you'll always find again features of chronic pancreatitis. And we said the commonest histologic variant is ductal adenocarcinoma. Other histologic variants that you may be able to see, but rarely, we have adenosquamous carcinoma, anaplastic carcinoma, and again, undifferentiated carcinoma with osteoclasts like giant cells. So the commonest histologic variant is adenocarcinoma, but on rare occasions, you may find these other histologic variants that I've already mentioned. So grossly, that's how ductal adenocarcinoma looks like when you look at it on the gross dissection of the pancreas. And then we have the histology, moderately differentiated cancer. And those are the histopathologic pictures. And it forms glands. It is forming glands. And that's why we are saying that is a poorly differentiated adenocarcinoma forming glands. And then in the lower picture, we have the poorly differentiated adenocarcinoma of the pancreas. And we are saying that it is poorly differentiated because you can't see formation of any glands. It is just diffuse infiltration with no glandular formation. And then in the lower picture, there is a perineural invasion, and perineural invasion means invasion of nerves. Invasion of a neural bundle is what we refer to as a perineural invasion. So the next slide is not important. This year, we are not going to talk much about treatment. We want you to understand the pathology of the pathology and not the treatment. So this slide is not important. And you don't expect us to ask you any questions on treatment. So I don't think I'm going to dwell much on the treatment of these tumors. What I want you to understand is the pathology of these tumors. So next slide. So other tumors of the exocrine tumors of the pancreas, we have several types. We have what is referred to as intraductal papillary mucinous neoplasm. We have mucinous cystic neoplasm. We have microcystic adenoma, solid pseudopapillary neoplasm, acinar cell carcinoma, and then pancreatoblastoma. I'm not going to talk much about these tumors because they are not common. And the tumor you're going to see commonly within the pancreas is the ductal adenocarcinomas. All the other tumors, exocrine tumors of the pancreas are uncommon. So the few things I can mention about the intraductal papillary mucinous neoplasm is that these are mucinous neoplasm that arise in the ducts and cause a cystic dilatation of the main pancreatic ducts. And it may progress to invasive adenocarcinoma. So intraductal papillary mucinous neoplasm is a benign tumor of the pancreas, but we know that sometimes it may progress to invasive adenocarcinoma. And that is how it appears on microscopy. We are saying that it is a papillary carcinoma, and in pathology, papillary means finger-like. And I'm sure you can see very many finger-like projections in this picture. So that is how the tumor looks like, the intraductal papillary mucinous neoplasm. The next tumor is a mucinous cystic neoplasm. And these form unilocular or multilocular cysts. These tumors often occur within the tail of the pancreas, and it will have no connection with the ductal system. It is more common in women. Just like you will have mucinous cystic neoplasms within the ovary. Again, mucinous cystic neoplasm of the pancreas is more common in women. Again, it can progress to invasive adenocarcinoma. that is how mucinous cystic neoplasm look like on grossly. The next tumor that is that occurs within the pancreas, we have the acinar cell carcinoma. And the acinar cell carcinoma, all the other tumors that we have mentioned originate from the ductal epithelium. But the acinar cell carcinoma will originate from the acinar cells of the acini of the pancreas. So the tumor that originates from the pancreatic acini is referred to as the acinar cell carcinoma. And lastly, we have the pancreatoblastoma. That is very, very uncommon. It is very, very rare. And is a tumor that occurs in children less than 10 years of age. And to tell you how uncommon it is, I've never seen one. And I think I've practiced medicine for more than 10 years, no, for more than 20 years. And in 20 years, if there is a tumor that I've never seen, then it means it must be very, very rare. And in my more than 20 years practice, I've never seen a case of pancreatoblastoma. And that is why I'm telling you that this is a very, very, very rare tumor. I said that today we are going to talk about exocrine pancreas, and endocrine pancreas is a lesson for another day. So that is the end of my lecture today. It is a very long lecture, long and tiring lecture. So a neoplasm of the endocrine pancreas we are not going to do today. And I welcome any questions that you may have, or any questions or any points of clarification or any comments. This is a time for you now. Thank you very much. Any
Thank you, Dr.
questions?
Ndungu.
Yes.
I think you were answering the questions as they were coming.
Yes.
So I don't know if
We
there
may
are any
not
new
have any
ones.
questions.
Did you answer this one? Kindly explain why DIC could be a complication of acute pancreatitis.
I think I tried to explain that. And I said
There's
that
another one. Why do? Yeah, you can still answer it again.
oh, I said that in cases of acute pancreatitis, usually the patient is very, very sick. Acute pancreatitis is a very severe disease, and I say that one of the features of acute pancreatitis is that there is release of those lipolytic and proteolytic enzymes that eventually destroy also the blood vessels, and these may trigger the coagulation cascade. And as you know, disseminated intravascular coagulation is a condition whereby there is a activation of the coagulation cascade, at the same time the fibrinolytic cascade, and it leads to it is also referred to as a consumptive disorder or coagulation disorder, because coagulation happens at the same time fibrinolysis, and that is how disseminated intravascular coagulation occurs. There is release of those lipolytic and proteolytic enzyme with the destruction of the wall of the blood vessel, and therefore activation of the coagulation cascade, at the same time the fibrinolytic cascade. I saw somebody asking about hypercalcemia, how it it leads to chronic pancreatitis. And the explanation of hypercalcemia leading to chronic pancreatitis. Remember, cases of hypercalcemia may lead to what we refer to as metastatic calcification, and sometimes some of those cases of metastatic calcification may lead to chronic pancreatitis, although there is even better explanation to this, where hypercalcemia may lead to chronic inflammation of the pancreas as a result of the activation of those proteolytic and lipolytic enzymes, hence leading to chronic pancreatitis. But again, you can go read further on how hypercalcemia leads to chronic pancreatitis. I believe when you read, you understand better how that hypercalcemia will lead to chronic pancreatitis. Any other questions or concerns?
Yes, Doc, there was a question. What is gallbladder sludging? I don't know. Sludging.
Oh, gallbladder sludging. Gallbladder sludging is a situation whereby there is increase in the density. You know, the bile that is found within the gallbladder. The bile that is found within the gallbladder is supposed to be in kind of liquid form. So when there is increased in the concentration, such that there is increased density of this bile fluid, then of course this will lead to gallbladder sludging. That is when there is a increase in the density of the bile, which is supposed to be liquid form. But when there is a how do I express it? When there is a increased in the density of the bile itself, then of course it leads to sludging. Sludging is when there is when there is laying down. I don't know what how to explain this, or when there is a increase in the density of that bile, then of course there is sludging of some of the components of the bile within the gallbladder. Any other questions or comments?
Yes, there was one more.
Yes.
Why do neoplasms arise earlier in our setting?
We think it is because of diet. Huh? We think it is because of diet. So we think the diet that
questions.
We think the explanation is a diet, huh? But there is no good explanation.
Well, okay.
There is no good explanation as to why malignancies occur earlier in our setting than in the Western world. But people think it is because of the diet. But nobody can tell you the actual facts why these tumors occur earlier in our setting than in the Western world. What we know that is that tumors tend to affect younger people in our setting than in the Western world, and we think mainly because of the diet. But The actual cause, nobody knows. Any other question?
The last one, do bile pH decrease with age?
Do bile pH increase with age?
I think it's a decrease.
Do bile
Decrease.
pH decrease with age? That one we can check. I may not remember about the bile. I may not remember about the pH of the bile, but that is something we can check in the books.
Okay, Doc. Thank you. Thank you so much.
Okay. If you look at your Mr. Khan, if you look at if you look at the lecture schedule, you will find that I'm supposed to give you a lecture. I'm supposed to give you a lecture on malabsorption next Wednesday on 20th. And if you look at 20th, 20 is supposed to be a holiday.
Oh.
So I tend to think when the people are making the lecture schedule, I think somebody did not note that 20th October is supposed to be a holiday. And I think that lecture on malabsorption, the lecture on malabsorption falls on a holiday. So what I was proposing is if you can suggest to me any other time before 20th, then I will be more than willing to give the lecture on malabsorption before 20th next week.
Right.
So you can tell any other time that you are available. It is not a very long lecture. 1 hour will be enough. So if you give any other time, and then don't tell me within hours, inform me maybe within a day. Tell me maybe tomorrow will I have some time, and so that I can be able to organize on my time.
Are you available tomorrow 7 to 8 in the morning?
No, tomorrow 7 to 8 is so soon. Maybe let's put it as from Thursday.
Thursday 7 to 8 in the morning.
Is Thursday okay with you? Thursday 7 to 8 in the morning.
Yeah, 14th October.
I think that one I can try. Let me call you tomorrow to tell you whether it will be possible. Because again Thursday we normally have the class we normally have lectures with the pharmacy class. But let's put it tentatively. Why don't we put it around midday, Thursday midday? What will you be doing on Thursday midday?
We usually have classes. I'll have to check. If we don't have a class, I will let you know and we can organize. I'll confirm with
instead of 7, I think anything between 11 and midday and 1 is better for me. Than very early in the morning.
Okay, I look for time.
Okay.
Yes, Doc.
Okay.
Thank you.
So thank you very much and for attending. Okay.
Yes. Have a good evening.
Okay.